Next up, we have Timothy syndrome, or TS. This is also known as long QT syndrome type 8, another rare channelopathy known for its pretty widespread multi-organ involvement.
That's correct. TS is truly a complex disorder. It affects the heart, yes, but also presents with congenital heart defects, distinctive facial malformations, syndactyly, which is fused digits like fingers or toes, developmental delay, and even immunodeficiencies. Quite a collection of issues. It was first reported in Journey back in 1992 and later detailed by researchers including Catherine Timothy in 2004, hence the name.
Wow. What's behind these widespread effects? How does one genetic issue cause problems in so many different systems?
TS follows an autosomal dominant inheritance pattern, though interestingly, most cases are due to de novo mutations. That means they're new mutations in the affected individual, not inherited from parents. The disorder stems from mutations in the CCAN1C gene. This gene encodes the CAV1.2 L-type calcium channel. This calcium channel is absolutely crucial for calcium influx in the heart, in neurons, and in other excitable tissues throughout the body. That's why the effects are so widespread. The specific pathogenic mutations impair the channel's ability to inactivate properly. This leads to prolonged calcium influx, which in turn causes markedly prolonged ventricular action potentials and, consequently, very long QTc intervals. There are actually two types. TS1 results from mutation in a specific part of the gene called exon 8A, and TS2 from mutation in exon 8. Some research suggests TS2 might have a more severe prognosis because exon 8 is expressed much more frequently in cardiac and neural tissues. Clinically, patients with TS are often born prematurely, sometimes due to fetal bradycardia detected before birth.
They are also highly vulnerable to general anesthesia, with multiple reports of cardiac arrest during surgical procedures. That's a major concern. Syncope has been reported in about 70% of patients. TS1 is characterized by distinct craniofacial features, including a receding hairline, a rounded facial structure, an underdeveloped jaw, a flattened nasal bridge, a thin upper lip, and a predisposition to dental caries or cavities. TS2 shows more variability but often shares the receding hairline, flattened nasal bridge, and thin upper lip. Syndactyly, that fusing of digits is unique to the classical TS1 phenotype. Neurologic manifestations are common, including speech delay, impaired communication, and ataxia, which is a lack of muscle coordination. Immune dysfunction leading to recurrent infections and problems with low blood sugar, hypoglycemia, have also been reported. It's a truly multi-system disorder.
What does the ECG reveal specifically for Timothy syndrome? What are the key electrical signs?
All TS patients exhibit prolonged QT intervals. The QTc typically exceeds 480 meters in TS1 and sometimes surpasses a staggering 600 meters in TS2. Very, very long. One study found that almost half, 47% of patients, had a 2.1 atrioventricular block, meaning only every second electrical impulse from the atria gets through to the ventricles. About 6% experienced bradycardia due to sinus pauses. Additionally, 47% displayed T-wave alternance, that warning sign we discussed earlier, associated with lethal arrhythmias. Life-threatening arrhythmias like ventricular tachycardia, ventricular fibrillation, and cardiac arrest have all been reported in TS patients. Echocardiographic findings, mostly from case reports due to the syndrome's rarity, describe structural abnormalities. Things like patent ductus arteriosus, patent foramen oval, ventricular septal defects, and even tetralogy of Fallot have been seen. Left ventricular hypertrophy has also been noted, though some cases do show a structurally normal heart. Genetic testing for the specific CRCID1C mutation is crucial for diagnosis.
Is there a consensus for diagnosing this incredibly rare condition?
While there isn't a formally established consensus like for some other syndromes, diagnosis is typically based on a combination of factors. The characteristic craniofacial features and syndactyly in TS1 are important clues. Specific ECG findings are key, particularly that extreme QTc prolongation, over 480 meters in TS1, often over 600 meters in TS2, the 2.1 AV block, and a history of lethal ventricular arrhythmias or cardiac arrest. And finally, identifying a pathogenic mutation in the CACNA1C gene, specifying exon 8A for TS1 or exon A for TS2 is definitive. Differential diagnosis includes Anderson-Tawil syndrome, Dravel and Lang-Nielsen syndrome, and other forms of long QT syndrome that might share some features. Data on the effectiveness of medical therapy is unfortunately limited due to the rarity. Beta blockers have been used but require cautious administration and careful monitoring for hypoglycemia, as they can mask the symptoms of low blood sugar, which these patients are prone to. Other antiarrhythmic treatments like calcium channel blockers, mexalotine, and ranelazine might potentially reduce arrhythmogenic risk, but more research is needed. Surgical correction is advised for any structural heart defects.
Due to the extremely high mortality risk associated with Timothy syndrome, ICD implantation is considered essential, even in asymptomatic patients. Pacemakers are also recommended for those with significant bradycardia or sinus pauses. It requires very aggressive management.